Hello, everyone. Thanks for taking the time to join us today. And we're having a webinar lectured by our speaker Dr. Zaafrany. And for today's webinar, it will take around 45 minutes. If you have any questions, you can write in the comment section. The speaker will answer the question for you. So now let's get started and welcome the speaker, Dr. Zaafrany. Thank you.
Thank you so much. Thank you so much, dear Amy, for the invitation and nice introduction. It's always my pleasure to join you for webinars and online teaching. It's not the first time, and for sure not the last. Today, I'm talking about shaping, as always, talking about shaping, my favorite topic. And the title of our presentation is Shaping with Purpose. Let the logic drive you. So many times I gave already lectures about shaping, talking about the sequence, the alloys, different system, and what's the properties of each one. But today I'm talking about a very specific point about shaping, which is the master apical finishing size or the master file. So it's me, Mohammed Zaafrany. I'm from Egypt, and I'm QL for Fanta Dental, lecturer, international endodontic diploma, Joma University in Spain, and I'm a winner of the Best Speaker Award of EDIC Dubai 2023. And now let's jump into our topic. So the endodontic paradox. Why we do shaping? Why we do shaping? Actually, our main objectives during root canal treatment are the biological objectives to remove microorganisms and prevent re-entry of microorganisms to our sealed root canal system. So, shaping step or during the shaping phase, our goals is to facilitate delivery of our irrigation to the apical portion of the canal. And after that, we need to enable a flow tight 3D obturation seed. So we do shaping mainly for two purposes: to facilitate delivery of irrigation towards the apex, and also to facilitate obturation and enable a fluid tight 3D seal to prevent re-entry of microorganisms. And during that steps, we need to make sure to preserve the natural apical foramen position, not to transport the apical foramen. This is very important. Otherwise, we are over enlarge the foramen poor ability to seal and also to clean. So it's very important to maintain the size and the integrity of the apical foramen during our shaping. And here comes the trap. Many clinicians think of the more we remove from the root canal system, the better cleaning. And yes, as long as you remove the teen from the root canal, you clean more. But this comes on the expense of the mechanical objectives of our non-treatment, make our tooth more weak and more liable to fracture, or it will be less resistance to fracture. So we need to remove the disinfected portion of the teen, or to disinfect that part, and at the same time we need to be minimally invasive or preserve the root canal structure, not to weaken the tooth and make it more liable to fracture. But before going into the shaping steps or talking about the master apical file, we need to understand the nature of the root canal system. Our root canal system is very complex, and I believe you already know that the root canal system is very complex. We have anastomosis, we have fens, we have lateral canals, many areas that our files can't reach or can't touch. That's why irrigation is very important. Here I'm showing you another case also, another graph that we can clearly understand or clearly see that we have connections between canals, and all that areas are not touched by our files. So files are important. Yeah, I agree. Files are important, but we want to know the aim or the objective of using files. They make the path, these files make the path for the irrigation to be delivered to the apical portion of the canal so it can disinfect areas that did not touch it by the file. On the other hand, our files already make the canal dirty. Yes, they are debrid, they are removing debris or routine from inside the canal, but as they are removing toward the bulb chamber, also our files pushing debris into osmosis and lateral canals and fins, make it more difficult to clean. Here you can see that our file is moving debris from inside the canal into the bulb chamber. Sure, we have to use irrigation during that step, but I just keep it without irrigant so you can see well how debris come toward the bulb chamber, and at the same time, our file push it also into canal irregularities and osmosis and connections. That's why irrigation is very important. I believe many dentists use this kind of sodium hypochlorite. It's fine. But to develop a protocol for irrigation, you need to have more control on the purity of your irrigant solution, concentration of your irrigant solution, and how also they store the material for disinfection. It's very important. So it's okay to use this one, but when it comes to concentration, uh, what we'll find on the home bleach, it's written it's about 5.25%. So if it is 4% for the company who produce this kind of irrigation, it's fine. It is not like for medical use, so it's fine if it is 4%. Also, if it is 6% or even more, they don't care that much. They are written, it's written there, it's about the percentage. Also, the way they deliver and store these products are not of much care, like what we are doing was medically grade irrigation solution like hypochlorite. So, about storage, concentration, efficacy also compared to medically grade hypochlorite for sure is poor. And on the other hand, here you can see many types of the home bleach. So which one already you are using? The one for colors, is the one for splashless, is the one for disinfection, the one for germicidal. So you can develop a protocol or you can't have good control over your irrigation and disinfection procedure while not having a reliable product like medically grades sodium hypochlorite, and for sure AGTAs that we need to incorporate into our irrigation and disinfection system. One more important thing is our irrigation needle and how we deliver the irrigant inside the canal. Here you can compare between two types of needle, and you can see on the left side the good fluid flow from the needle vent. So with good fluid flow, you have better detachment of debris from inside the canal. On the right side, you can see the other needle where we have like droplet coming from the vent. So it is not like a good flow. So you put your irrigation and it's static. And in literature, already we have what we call the fluid flow phenomena. It's a mechanical component of irrigation. Here, in that study, they are showing that the good fluid flow from your irrigation needle would increase the cleaning efficacy in the apical part, also better irrigation replacement, and it will improve the mechanical detachment of debris and tissue remnants. So I can give you an example. If your hand is not clean and you open already tap water, if you open it with low flow, so it will clean but not that gone. But if you have high flow from the tap water, it will be more clean even without touching. So you irrigate, and this is the mechanical component of irrigation. Same way we need our needle to be. We need to have a good fluid flow from the irrigation needle to detach debris from the canal and also for better irrigation replacement. Here you can see how good flow from the irrigant or irrigation needle can detach debris already from the root canal system. That will enhance the cleanliness and disinfection to our root canal system. These points we need to keep in our mind during shaping. So This is the purpose of our shaping: delivery of irrigant, doing disinfection. So this is the main purpose. That's why in cases of open apex or very wide canals, we are not doing shaping in the regular sequence, or even sometimes we can skip files using only irrigation and activation to irrigant, because our aim and objective of shaping is already better delivery to irrigation and disinfectant solution to the apical portion of the canal, and also to facilitate obturation. So in case of wide canals or open apices, shaping is completely different. It is not like the conventional way. Also, more important is activation to irrigant. And we have many kinds of irrigant activation, like sonic, air sonic, ultrasonic, laser, negative pressure, many ways we can do. Even for anyone who don't have these devices, he can use the manual agitation using the master Kunga taperka, just cut 2 or 3 millimeter from the master Kunga taperka, and with pumping action, it can do the activation to the irrigant instead of being static hypochlorite inside the canal. That should improve the cleanliness and disinfection through our system. Here I'm showing you many articles in literature. All these articles showing a great evidence on the importance of ultrasonic irrigation and how the activation with ultrasonic is more effective than using syringe alone. Another one also showing that different kind of activation, like the manual dynamic activation, the passive ultrasonic, all these activation methods are better than using the conventional needle irrigation alone. Also, they both much care about the concentration of the hypochlorite in this study. Another one showing that passive ultrasonic activation is favorable on pulp tissue removal and hard tissue debris removal, better root canal disinfection, and overall improvement of root canal debridement. So what I want to say is, if you're doing shaping just to have these white lines or continuous white lines on the radiograph, maybe at the end your result or your outcome would be zero, because you did not define your goal. So we need to define your goal. You need to follow the logic behind each step. So I agree that no need to remove too much tissue from the root canal system by files, because already files are not killing bacteria. Hypochlorite does. Hypochlorite is killing bacteria. So this is more important, is to deliver the irrigation and activate it. And in studies, we don't have like agreement on how long should be the activation: 1 minute, less than 1 minute, more, 3 to 5 minutes, but all agreed on the importance of the activation to our irrigant solution. Here's the Actor Eye Pro, the cordless ultrasonic device from Fanta Dental. Very, very effective ultrasonic device for irrigant activation. But you need to make sure using the ultrasonic devices should be limited to the straighter portion of the canal. So if you have a curved canal, you have to take care not to ledge, not to perforate, because already these devices are strong in activation. And if you use it the wrong way with pressure, usually you may cause injury to the root canal walls. So with ultrasonic activation, you'll have 2 or maybe 3 effects, like the acoustic streaming, the cavitation effect. And here I want to take the chance to describe to you what is cavitation. Anyone who tried the use of ultrasonic activation before, for sure, he saw bubbles generated inside the canals because of the activation by ultrasonic. Actually, these bubbles would explode inside the root canal system and would hit the walls, and it will loosen the debris, make debris are more in the solution or into the hypochlorite, so removal would be easy. So cavitation effect is the formation of bubbles, and these bubbles, it's tiny thousand bubbles. They are too much. They are, and once this bubbles formed inside the canal, it will explode, and with this explosion, it's doing like stroking to the root canal walls, and that effect will cause uh, debris removal or debris detachment. And here comes the effectiveness of the ultrasonic activation, and for sure, acoustic streaming also transferring the ultrasonic power into acoustic streaming make the solution take more debris from the walls, from the lateral canals, and improve the cleaning. And sometimes also we have heat generation, especially on high power ultrasonic. We have heat generation, and we know that heating to titanium chloride would also improve the cleanliness of the root canal system. Now we come to the main question of this presentation, the apical finishing. How to select the master apical file? And this question is for you. To which size should you end your preparation? I know many would say, like, doctor, I have a system, last file is 35 table 4, so I will end my preparation to 3504 because this is the system. Some would answer and say 3 files after the initial file. So if the initial file is 10, they would increase to maybe 25. But what about in case of initial file is 30? How much would increase? It's also a question. Another one would say, I will continue shaping till I see white debris on the tip of the file or the apical portion of the file. So the file is cutting 360 degrees circumferential. However, these are not the answer for the question, what should be the master apical file? Actually, the selection of the master apical file would based on which size of preparation would allow better delivery of the irrigant to the apex. So more or less based more on the size of your irrigation needle. And most of us are using the 27 gauge needle, not 30, because 27 has more fluid flow, better fluid flow, because of the size is quite bigger than 30. 30 is smaller, so you need to put more force on the plunger of the syringe to push irrigation into the apical portion. So most of us are using the 27 gauge needle. So to deliver the irrigation, we know that the irrigant would not exceed the tip more than 2-3 millimeter. So most of the studies suggest the sizes of 25 taper 6 or 30 taper 4. There is no agreement on definite size. Yeah, in literature, there is no agreement on definite size, but the agreement is on which size would allow you to deliver irrigation into the apical portion of the canal. But most of them agreed on 2506 or 3004. That's why you'll find any file system you are using either end by 2506 or 30/4. Sometimes you have larger size files in your system, and you'll find that company recommend using larger files for larger canals. However, with 3204, 2506, we are in good shape in terms of allowing good delivery to the irrigation into the apex. And it's fine with normal cases, with regular cases. Here comes the logic. I'm not enlarging to the size that is now my system. I'm enlarging to a size that allow me to deliver irrigant to the apex. And this is logic. But what about cases which are very narrow, canals, cases with severely curved canals, or maybe with multilinear curvature? In that cases, if you try to enlarge more to 2506 or 3004, maybe you may risk your treatment by perforation or ledging, or maybe file separation. So we need to compensate, or in that cases, we need to end our preparation at smaller size than 2506 or 3004. Maybe 2504 would be okay. Sometimes 2004 also would be okay in terms of safety. And here, as we are preparing our canal to a smaller size, we need to compensate for that shortage in enlargement by paying more attention to our irrigation and our delivery methods. So in narrow cases or narrow canals, cases with severely curved canals or cases with material curvature, we end our operation at smaller size, and we need to compensate for the smaller size by paying more attention to the delivery methods and irrigation concentration, the correct concentration, the timing of contact, and also the efficacy. So, okay, this is for the very narrow canal. What about for wide canals? Suppose you already have initial size of 30. So already canal is shaped. So to what size you would enlarge your canal? Actually, if the initial size is big, like 30, 35, maybe bigger in cases of upper anterior or young age patient, for cases like palatal canal and maxillary molars or distal canal and lower molar, also sometimes they are wide, because the initial file could be 30 or 35. In that case, actually, we don't enlarge more. Maybe one or two files extra or larger than the initial file, just for minimal mechanical debridement. So it is not for irregular shaping, it's for minimal mechanical debridement, removing that part of the dentine that was enclosed to the infection or the microorganism, minimally debride, because already our irrigation could be delivered easily toward the apical portion because of the widening of the canal. So here we can see how the logic drive us to select the master apical file. Regularly or regular cases, 2506 or 3004 would be fine. 2504 also would be fine in some cases. When it comes to very narrow canals, we may end to a smaller size and compensate by paying attention more to the irrigation. And in wide cases, no need to enlarge more, just one or two files for minimal mechanical debridement. All these considerations or the logic behind this is to deliver irrigant to the apex. The main purpose of shaping. That's why the title of our presentation is Shaping with Purpose. Try to define your goal in each step. Once you define your goal, at the end you will have a result. Otherwise, maybe your outcome of treatment would be zero if you did not define the goal. For whom would say that we need to enlarge the canal to a size that allow debris or engagement 360 degrees at the apical portion of the canal, I want to say that the complete round canals rarely exist. If you're talking about the foramen, the completely round canals or foramen rarely exist. And we know that our files shaping the canal to around the cross section. So if you want to your file to touch all the canal walls, imagine you have an oval foramen like this one, and this is your file. If you want, you would over enlarge the canal and transport the foramen just to make sure that your file touched all the canal walls. And for sure, this is wrong. Transportation should be avoided, and over enlargement also should be avoided. That's why it's enough to enlarge to 30 taper 4, 2506, or as we agreed or as we discussed previously, to based on the canal anatomy and the canal geometry, we can choose our size. And for areas like this, we depend on irrigation and disinfectant to dissolve the organic tissue and remove also the inorganic part of the pulp system or the root canal system. So for that part, irrigation would take care as long as you already gave the pass for delivery. So once you give the path for delivery, disinfection will be easy. And here comes also the introduction of functional files. Functional files like the AF Max Shaper, AF Max Finisher, these files are, we call it dynamic files or functional files because it adds more advantage to the root canal or regular root canal shaping. As you saw here, here comes the shape of the file. These files, we use it on high speed. So on high speed, that curved part of the file would expand inside the canal because of the high speed, 1000 RPM, 800 RPM also. Some functional files are recommended to be used between 1,000 up to 3,000 RPM, because the more speed, the more expansion of this curvature. This is the AF max finisher. For the AF max shaper, we have more curvature in the on the file, and this curvature on high speed would expand, so it would touch areas that did not touch it by conventional or regular files. So these files also we can use it during root canal shaping. It will add more into debridement. So we can use already AF Max shaper and finisher for regular shaping. This is a shaping file. It's a AF Max 1. It will end the preparation up to 2504 because of the speed. It will end up to 2504. And if you use it more, it will enlarge the canal more. And we can use this file on speed from 800 to 1000 RPM with a torque 1 Newton per centimeter. So here are the files that would aid or help in mechanical debridement more than the conventional files, especially in wide or oval canals where we don't have complete touch or complete contact between the files, conventional files, and the root canal system. So here I'm showing you, this is a low speed video or slow video, So just to show you how the file adapt by speed on the root canal anatomy, especially in case of oval canals. This is a distal canal in lower molar. So here you can see how the file, some would call it activation, but I'm not considering this activation. Activation methods are known, but this one is functional files or dynamic files that would aid into better debridement and better cleaning to the canal system. Now I'll discuss with you some cases where we will see how we adapt these concepts or the logic behind shaping into the clinical application. So for a case like this, with really curved canals, if you try to end your preparation to 3004 or 2506, most of time you will cause injury to the root canal system either by ledging, perforation, transportation, straightening to the curvatures, stripping, and sometimes, or you may break the files. So here, this is the sequence that I've used to shape a canal like this. I end my preparation by 2004. So it's a smaller size. And at the same time, I paid more attention to irrigation. Intracanal heating to the irrigant is very effective method in activation to the irrigant or increase the efficacy of the hypochlorite, because with intracanal heating, we decrease the surface tension of hypochlorite, make it better flow and better penetration into the internal tubules. So here you can see this is the sequence starting by 2506 as a pre-flaring file. So this one is used just to gain a straight path or a straight line access to the mid-root portion. So by pre-flaring and brushing toward the outer wall, we were able to do straight line access. This followed by manual glide path by size 10. And during glide path, don't be in a hurry, because if you have an error or mishap during glide path, correction would be very difficult. So our file 10 reached to full wall length. Then by 1503, my best and my favorite mechanical glide path file was a F1 design. And 2004 here just for the first curve or the smoother part of the curve. Then again, size 10 to full length till it becomes super loose. Then 1303, 2004 to full length. So here is considered enough. And you may spend more time by 2004, so it will enlarge the canal bigger than its size. As long as it's safely reached, you can use it like, I know that we should use it in picking motion, the shaping files on up and down or filing motion. However, a little bit of brushing with 2004 will enlarge the canal more for better delivery of irrigant. So here, the logic drive us to select the master file. For sure, the logic backed by science. Another case, very interesting one with material curvature here, and here this canal is wide. So for pre-flaring phase, again 2506. And here also I want to say that some clinician or some dentist say we should avoid the use of big tapers like 25 per 6 or 30 per 6 or whatever the size. But I can say that I can use these files as an orifice opener or pre-flaring files only for the first 3 to 4 millimeters. It's fine. It's fine to use this file in brushing motion just to pre-flare the canal. So here I'm not using it as a shaping file. For me, I would always prefer to end my preparation to taper 4 files, like 30 taper 4 or maybe 25 taper 4. But still, I can use bigger files for coronal preparation, mid-root preparation, not for the apical finishing. So here I use 2506 for pre-flaring, then manual glide path, mechanical glide path. This one is the F1 1303. Here I'm showing you the 2506 for pre-flaring with brushing motion. So we are enlarging the coronal portion of the canal. Pre-flaring step is very important step. And as a dentist or endodontist that dealing with referred cases, I can say that most of mishaps happened with preferring dentists are because they are not doing good pre-flaring. Pre-flaring is very important, especially for beginners. Yes, expert can skip pre-flaring steps or using the orifice opener or orifice shapers, but for beginners, we need to get trained on doing pre-flaring in first phase of shaping, so it will make us avoid mishaps that could happen during shaping. Here the canal is pre-flared. Then I decide to end my preparation in the mesial canals, again to 2004 because of the multilanar curvature, the narrowness, and for the distal, 3504. Again, it is not a standard to end operation to single sides. In the same case, you can see based on the canal geometry, 2004, 3504 for the distal because it's already wide. These are the F1 from the essential kit with a flat side design. The logic also behind choosing 2004 is to not to risk our procedure, not to have change to canal geometry and also file separation. We need to avoid file separation. And for the distal, wide and easy, so we can reach safely to the full working length because safety comes first. Safety comes first. And here is the obturation, and here is the radiographic workflow. You can see that we maintain the original canal anatomy, original canal shape, and because that the two mesial canals have one common foramen or they are confluent, 2004 in mesial and 2004 in mesiobuccal and mesiolingual, I believe that the apical foramen now is oval because we have a rule. If you have two canals which are round, when they meet each other or when they become confluent, the cross section of the canal become oval. That's why we rely more on activation to irrigant, concentration of hypochlorite, time of contact. This is very important to pay attention to more than shaping. Another case here, very, very interesting case with narrowness and all canals. Actually, we can see here that we have like calcification or calcified entrances. Let's see how we manage this case and how we decide to choose the master apical file for each canal. This was treated long time ago and now patient develop symptoms. Here is exposure, the bulb is necrotic. And from that side, I can do my deroofing. Connecting the two exposure sites with pair, just to do the deroofing step. Pulp stone inside the pulp chamber. Access refinement using ultrasonics. Ultrasonics are very important to implement into your daily practice. If you're not using ultrasonics, you're missing too much. And then open coolant to flush away debris that forming during the refinement step. And here's distal canal, palatal, and mesobuccal. Sure, most of dentists would start by using manual files, trying to negotiate the canal. But for me, I would go directly with a pre-filling step. So before introducing manual files, I will start by brief-layering step. Usually the coronal portion of the canal is patent, so it is safe to go by brief-layering file. And here I'm not talking about orifice openers. As I told you, you can use any file with small tip diameter and large taper, like here 2506 from the F1, for brief-layering passively. Don't push the file. The file should engage alone because of the serrations. It will engage alone inside the canal. Your job or your homework is to take the file out. It engage, proceed toward the apex, you take the file out in a brushing motion, passively. Now I have better delivery to the irrigant to the middle portion of the canal, and you can see also the fluid flow, the phenomena that we talked about before. And here for brief-layering for the mesobuccal. I know many beginners would be afraid of introducing rotary file or mechanical files directly in the canal before manual files. And fear is okay for them, because if you're afraid, you'd be safe. If you're afraid to introduce your rotary files directly into the canal before the manual, if you're afraid, it's fine. You can get a manual file and introduce it into the first 3-4 millimeter of the canal, not to the full length. And if your file goes without resistance, know that it's safe to do brief-layering step. We call it coronal patency. If you have coronal patency, it is safe to do brief-layering with rotary. And here I'm continuing shaping the canal. This is the 2004 for the mesobuccal canal. F1 central kist. I would encourage you also to review the Fanta Dental Global page for previous webinars. We talked more in details about rising, the F1 essential kit, R1 many systems with many advantage. Complete shaping for mesobuccal canal. I just move the video. And for the palatal, I'm ending my preparation to 3504 because it was already wide and large. And here is the canal MB1, MB2, and this is biceramic sealer for obturation. For sure, MB2 canal, no need to over-enlarge, because of the thin root at that part, and also because of presence of the groove. So it is dangerous if you try to enlarge the MB2 canal. So 2004 is fine for the MB2 if you find difficulty in enlarging more, and here's the case. So mesobuccal, MB2, distobuccal, and palatal. And here we can see that each canal was prepared to different size, based on geometry, based on difficulty. So, as I told you, let the logic, backed by science, drive you in selection to the master apical file or to enlarge which size you need to enlarge the canal. Another case of retreatment, and here you can see that we treated these two mandibular molars. Here, after obturation, you can see here small size preparation, poor obturation, here better enlargement, because especially with uh, retreatment cases, we need to do good debridement to the canal. Here is a fourth canal. And let's see a case of a treatment using rising system. So same concept, same logic behind shaping. So again, define your goal. Whatever system you're using rising, you're using R1 mini, reciprocation, you're using flat side design file like the F1, whatever the size, whatever the design, the speed, the torque, the different recommendations, just be driven by logic, backed by science. Here I'm removing all the tubercle using the ultrasonic tip. You'll see that in each step we're doing ultrasonic, especially for the advanced part of the treatment, if we're doing the treatment or managing broken files classification, ultrasonic are very important. Access refinement. Open coolant to flush away debris. Here, pre-flaring with the RR from the rising system. For sure, the video is moving fast. I'm not doing like this, actually, but the video is moving fast. So RR for pre-flaring and also removal of the coronal portion of the tubercle. So we are using here rising system for the treatment. So we can use it for primary treatment, primary shaping, and also for retreatment. It's very effective because of the semi-active tip. It will engage more the canal because also of the variable cross-section. Very nice system. Here is the RR. And I'm moving directly to R2, 2504, because that's a retreatment. So no need to go by the R1, which is the glide path or mechanical glide path. Maybe if I have blockage or narrowness at the apex, I would use the mechanical glide path file before 2504. Here you can see that very effective in removing the tubercle rising system. And don't forget, between each file, you need to irrigate well. And here I'm ending my patient to 3004 using the R3 activation by Actor Eye Pro. And here you can see how effective is the formation of the tiny thousand bubbles. We call it cavitation, as we discussed before. So now we already have the path to deliver irrigation and also to enhance disinfection by using activation methods like ultrasonic, and in that case was done by the Actor Eye Pro. Not cleaning, not disinfection, especially of use cases of treatment. And here is the case after finishing the treatment for both molars. So now we come to the end of our lecture today or our presentation, and I have some take-home message for you. During shaping, you are the pilot, and instruments are only the tools. So you are the driver. Changing sequence, hybridize your system or files is based only on you, and it should be tailored to each canal. The most dangerous clinician is one who follows the file blindly. Don't know about the properties, don't know about advantage or disadvantage, don't know about the performance of the file. So the clinician himself is a dangerous, not the files. Move beyond habit-driven technique. So instead of following the same files or same system, same sequence, no, let the anatomy, biology, physics inform about every decision and let anatomy, biology, physics drive you by logic. Purposeful shaping is not about which system to use. No, it was never about systems. Yes, we need to know about systems and how they evolve, but it's more about why you use this file. You need to know why you use the file, when to use it, and what you expect it to achieve. So these are my take-home message for you. I hope I was able to deliver or focus about the information about selection of master epical file and how to be driven by logic, backed by science during selection of master file. So thank you, and I would like to thank you all for your interest, and thank Fanta for hosting this webinar. It's always my pleasure to be with Fanta Dental delivering scientific informative lectures. See you soon. Bye-bye.
Thank you. Thank you, Dr. Zaafrany, for the wonderful course. And looking forward to seeing you next time.
Thank you so much. Thank you so much, dear Amy, for hosting, for the invitation, and also for your presence during the lecture. Thank you so much.